Good afternoon, and welcome to this webcast of the Methodist DEBAKEY Cardiovascular Journal. I'm Mike Quiñones, the editor-in-chief of the journal, and this webcast today is on the current issue of the journal on cardiovascular prevention. This is a picture of the printed version of the journal. The journal now is also available online, and hopefully you can see a little picture of the online page. Very easy to find on the journal.houstonmethodist.org, or simply Google it. It will come out immediately. Before we go any further, just to remind everybody, as we proceed with the webcast, if you have any comments or any questions for us, you can text them to us by texting DEBAKEY to 37607 and then put in your question. The issue that is current in the journal is on cardiovascular prevention. And this is an issue that we thought was very important because as cardiologists, for quite some time now, we have thought that all we have to do for prevention is put people on statins and give them some aspirin. And you're going to hopefully hear tonight that there's a lot more to prevention than just doing that. And in fact, even aspirin may not always be indicated. So I'm indebted to the guest editors for this particular edition of the journal, Dr. Khurram Nasir, who is the director of the Center for Cardiovascular Prevention here at Houston Methodist. Khurram is an internationally recognized expert in cardiovascular prevention. He could not join us tonight, but we are very much indebted to him and his colleagues who are with us tonight. Dr. Miguel Cainzos, who is going to join us from his office through Zoom. He is an associate director of Preventive Cardiology Research, and here at Houston Methodist. And Kershaw Patel, who is sitting here with us on my left. He's a cardiologist in our department, and likewise a colleague of Dr. Nasir, and very much involved with our Cardiovascular Disease Prevention Center. Also joining us is Dr. Eleonora Avenatti, on my immediate left. Eleonora is currently a resident in internal medicine, but before that she spent several years doing research with us, particularly in cardiovascular imaging, and she's now also involved in research in cardiovascular prevention. And even though she looks young, she's quite an expert in the topic already. So with that brief introduction, I will pass it over to Dr. Patel, who is going to take it on and bring some other speakers.
Thank you, Dr. Quiñones. We are very grateful to have been able to contribute to this edition of the DEBAKEY Cardiovascular Journal. It really speaks a lot to the leadership and the vision of this journal, and we want to extend a thanks on behalf of my co-editors, Dr. Nasir and Dr. Cainzos, for giving us this opportunity, so thank you. Additionally, we would like to thank all of the authors and the entire editorial team who helped us put together such an amazing issue for this journal. And to start today, we're gonna, just to give you a little bit of the format, we're gonna have somebody, ideally from one of the contributing authors for each of the specific articles that we have, if they could join us, contribute, and have a lively discussion, and with some Q&A, as well as a few of us are going to help highlight some of the other key points of some of the other issues for those articles that we were not able to have authors join us today. So I have the distinct privilege to start us off with the introduction of our first lead author, Dr. Shapiro. So Dr. Shapiro is joining us from Wake Forest. He's the director for the Center for Prevention of Cardiovascular Disease there. He is the Fred Parrish Professor of Cardiology and Molecular Medicine, and he helped lead our first article that we're going to discuss today, titled "The Questions on Everyone's Mind: What is and why do we need preventive cardiology?" So I'd like to welcome Dr. Shapiro joining us from North Carolina, and we look forward to getting some of your insights on this beautifully written article with us today. Thank you.
Thanks so much, Dr. Patel and Dr. Quiñones. I agree that it says a lot about the journal, the fact that you've devoted a whole issue to prevention of cardiovascular disease. I think it also speaks really volumes as to where we've come in cardiovascular medicine in terms of understanding the importance of prevention. I'm just going to share my screen and just review some highlights from the paper that we put together. Is that sharing?
Yes.
Okay. Okay. So what is and why do we need preventive cardiology? So this audience obviously knows that cardiovascular mortality remains the number one cause of death in not only the United States, but the entire world. There obviously has been significant progress over the last few decades in terms of bringing down cardiovascular mortality, but really the focus has been on treating manifest cardiovascular disease rather than preventing it. And we now have greater systems of care, greater technologies that allow individuals with cardiovascular disease to live longer, but with significant disability. So, with CCUs and EMS and door-to-balloon times, as well as advances and all of the technologies, stents, revascularization strategies, ICDs, mechanical circulatory support, LVADs, transcatheter valves. I mean, it's incredible what's been achieved, but that is not actually preventing cardiovascular disease. That is allowing people to live with cardiovascular disease. And that, of course, comes with a very significant disability. The other thing I would say is it's a bit of a misnomer. We frequently hear people say something like I said, there's been 4 decades of declines in cardiovascular mortality. Well, that was true. But if you look at these figures here, the declines really ended in the mid-2000s. And unfortunately, we are seeing an uptick in cardiovascular mortality. It's quite sobering. So, and even in the developed world, we're starting to see increased cardiovascular mortality, and that is largely due to the burgeoning epidemics of obesity and diabetes. Unfortunately, also in the United States, there's very limited potential future gains that can come from further reducing very low smoking prevalence at this point. And something that, of course, that's on everybody's mind is the persistent inequalities in mortality risk, which is something that needs to be dealt with. But let me just give you a brief historical perspective of preventive cardiology and tell you my thoughts on where I believe it's going. I think it really all started in 1948 with the Framingham Heart Study. That really was the landmark study that identified the risk factors for cardiovascular disease. It was coined from the Framingham Heart Study in a seminal paper published in 1961. And so, of course, high cholesterol, high blood pressure, diabetes, and smoking were identified. And then, of course, a whole bevy of clinical trials ensued to see if lifestyle modification, and at least the medications we had at the time, could reduce cardiovascular risk. And certainly there was some success. But really everything changed in 1994 with the publication of the 4S study, which was the first of the statin mega trials, which demonstrated that in secondary prevention, the use of simvastatin versus placebo was associated with dramatic reduction in cardiovascular events. And the success with statins is really what launched the whole idea of evaluating and manage blood cholesterol levels. And that really was the birth of the so-called lipid clinic. And that name still persists, even though it kind of drives me crazy because I think we can do a whole lot more than just evaluate and manage lipids. So as I say, expert management of lipids is part of preventive cardiology, but a modern program really needs to go well beyond that. So we need to take on lifestyle, diet, exercise, weight management, smoking cessation recommendations. Of course, lipids remain central, but we also have to go beyond lipids and taking care of blood pressure. And now cardiologists are taking on a very central role in the management of diabetes, inflammation, and thrombosis. So there's a lot that we can do. Now, in the review that we have in the journal, we go through some of the very common referrals to preventive cardiology, which you can look at your own leisure. This just gives you a basic idea of the kinds of patients that typically are referred to preventive cardiology programs. But the idea here really is that we have so much more that we can offer patients. So you heard in the introductory remarks, statins and aspirin. Well, that's what we had for many, many years. There really wasn't a compelling need for preventive cardiology, for risk assessment, for a long time, we just had the Framingham risk score, which is, a quantitative risk assessment tool. And it's pretty crude in its ability to predict 10-year risk. And in terms of management, we obviously have lifestyle modifications, the advent of the statins in the late 80s and into the 90s and forward, blood pressure medications and aspirin. But now we can offer a lot more. So in terms of risk assessment, we're well beyond the Framingham risk score. We have better quantitative risk assessment tools. But beyond that, we have much better tools, which I'm going to get into in a moment, so that we can really identify those individuals who are at the highest risk and who are going to benefit from the most aggressive medical therapies. And on the other hand, sometimes something that gets lost in the equation is prevention of cardiovascular disease, or preventive cardiology as a discipline isn't only about getting people on medications. There is a large swath of the population that is actually at low cardiovascular risk. And if we can identify them, they don't necessarily need to go on long-term chronic medications. They need to live a healthy lifestyle, and they can stay free of cardiovascular disease. And we can assess risk in a much more refined way because of advances in subclinical atherosclerosis imaging, novel biomarkers, and really now we're starting to see the advent of polygenic risk scores that can be used at a very early age to get some handle on a lifetime risk of cardiovascular disease. Of course, we have a lot of new medications that are already available and approved by the FDA, and really some exciting medications in the pipeline that go beyond just lipid management and blood pressure management. We've already seen what's happened with diabetes and thrombosis. Now, some new anti-inflammatory agents and many other new drugs in the pipeline to address all of these different risk factors. And we're beyond just using small molecules. We have all of these new tools. We have monoclonal antibodies, antisense oligonucleotides, soon small interfering RNA, and really some sci-fi things in the not too distant future. I'll conclude here with, again, just the notion that we really need to address all risk factors. Here are the two seminal publications with PCSK9 inhibitors, the FARIA trial and the Odyssey outcomes trial, that demonstrated improved outcomes with the use of very potent LDL lowering drugs. This is the FARIA trial. This is a secondary prevention trial in high-risk patients. These individuals were on standard of care and then randomized to either evolocumab or placebo. And you can see that the median achieved LDL cholesterol in those individuals who were randomized to evolocumab was 30 milligrams per deciliter. That means half of the treated population had an LDL under 30, so really, really low. And many people actually prophesized that this is the end of coronary disease as we know it. But if you look here, the individuals on the red curve represent those who received evolocumab and achieved very low LDLs. And we see that there's still this tremendous amount of residual risk that remains despite the incremental improvement in outcomes. So it is not the end of coronary disease. Unfortunately, event rates remain high despite functionally eliminating LDL from the risk factor equation. And we've just been focusing on LDL for these last decades, partially because it was a successful strategy, and partially because those are the tools that we had. But the point I'm trying to make is there are diminishing returns from just going after LDL, and we have to be much more comprehensive. The good news is, whereas just years ago, we knew about other risk factors, we just didn't have the tools or the evidence to suggest that targeting them would improve cardiovascular outcomes. But now we have a lot of evidence that going beyond LDL, other lipid fractions are important, triglycerides, potentially lipoprotein(a), and we certainly have evidence about treating inflammation, thrombotic risk, and we've seen, of course, in the diabetes trials, the success that has been achieved with the novel diabetes agents. So I'll just conclude here by saying the disturbing trends in cardiovascular risk factors and cardiovascular mortality really need to serve as a call to action. And our attention really needs to turn from intervention to prevention. And I believe that the development of preventive cardiology programs is a positive step in the right direction, and really pleased to join you today. And you guys are definitely a shining light in the country as having one of the best preventive cardiology programs in the country. So congratulations on that. Thank you very much.
Thank you very much, Dr. Shapiro. And we know that you have to leave us soon to do another important commitment. So I'm going to ask Dr. Patel to make some comments or ask you any questions that have come through.
So thank you for that lovely article and excellent summary of the findings and all the main points of that articles. So Dr. Shapiro, I know you've written about this and talked about it, and we've had some conversations about training programs for the next generation of preventive cardiologists. Can you kind of summarize for us, because there's a lot to pack in there for developing the next leaders in the field. Specifically, you talked about the different categories of residual risk, and that requires a lot of expertise in multiple domains. There have been proposals for cardiometabolic training programs, preventive cardiology fellowships, and then whether or not this should even be housed within cardiology or just internal medicine or primary care. Where do you see the future is for training the next generation of preventive cardiologists?
How much time do you have, Kershaw? That's a beautiful question. It actually deserves an hour in its own right. And you're right, this is something that I'm very interested in myself. I really do believe it's time to develop standards, not just of practice of preventive cardiology, but in training. There are several issues for trainees who are interested in preventive cardiology at this point. One is that there's not many training programs available. Of course, none of them are ACGME approved, which really causes funding issues. So not many fellows would necessarily be able to pursue that. And then if you look at the various training programs that do exist, one is as different from the next. They're absolutely so heterogeneous. The focus is different from one program to the next. So I do think it's actually time, and this is maybe a call to action for those in preventive cardiology to probably put our heads together and really hammer out what the needs are in terms of standardization of training. I have some definite thoughts in that area, but I think you're right. There is this tension now between the sort of the rise of cardiometabolic clinics versus preventive cardiology, and then of course there's lipid clinics that still remain that are solely focused. And I sort of view these as concentric circles. I think lipid clinics really are useful, but they're just too narrowly focused. I think cardiometabolic clinics take on the lipid clinic and then offer more. And from my view, I think preventive cardiology subsumes everything. I think you can house lipid expertise, cardiometabolic expertise, and beyond in preventive cardiology. But of course, that can be debated. As to where these should be housed, I'm a cardiologist, so my bias is probably in division of cardiology. But that's not to say that I think only cardiologists should be participating in preventive cardiology programs. I feel very strongly that a multidisciplinary approach is the way to go. So I think cardiologists, endocrinologists, primary care physicians, as long as they have the expertise and the interest, the commitment, I think that's the way to go. Beyond that, of course, we need dietitians, APPs, clinical pharmacists, exercise physiologists. There's a whole range of individuals and a whole diverse range of expertise that's required to really deliver excellent prevention of cardiovascular disease clinical care.
It's a topic for a 1 hour discussion, because we cannot forget also that to penetrate the whole community of patients and people in different cities, primary care doctors have to be brought on board and educated. So this is, I agree with you, it's an important topic. And I think it's going to be evolving, and with the leadership of people like you, I think hopefully we'll get there. Thank you so much.
Thank you.
Great. So thank you, Dr. Shapiro. For our next talk, kind of going in this theme of the timeline, as Dr. Shapiro nicely laid out the Framingham Heart Study and then how we developed all the way to the 4S trial and where we are. When we talk about the timeline, sometimes we forget about young individuals developing cardiovascular disease. And so our next speaker who we're going to have is Dr. Ron Blankstein, joining us from Boston. He is the Associate Director for the Cardiovascular Imaging Program. He's the Director for Cardiac CT, and he's a Professor of Medicine and Radiology at Harvard Medical School. And so we want to welcome you, Dr. Blankstein, for joining us here to talk about the article, Not All Heart Attacks Are Created Equal, thinking differently about acute MI in the young. And we know that you've done a lot of great work with the Young MI Registry, and we are excited to get your thoughts on the article that you guys recently published with us. Thank you for joining us.
Yeah, absolutely. Thank you very much for having me. It's such an honor to be part of this program. And of course, to follow Dr. Shapiro, who just gave such a great overview. But I will start with this, that in generally, preventive cardiology has been a very successful field. And I'm saying that because after the year 2000, we've actually noticed a reduction in myocardial infarctions across the US. And you can debate, is it the statins or is it that we're doing a better job in preventive cardiology? But regardless of the reason, we've actually seen some advances. And we've all been very happy about that, except that when you look at the statistics, the reduction has not been experienced by young individuals. So every group has fewer events, fewer myocardial infarctions, fewer ACS, fewer death. And in young individuals, some studies have shown a slight increase or at least a stagnation. And that caught my attention, that statistic, because as a cardiologist, when I was rounding on our inpatient service, and this is, now a decade ago, I saw a lot of young patients, folks in their 30s and 40s, all being admitted with a myocardial infarction. And to me, it was surprising because every time I talked with them, they thought they were incredibly healthy up until the day of the MI. Even folks that had frank risk factors, diabetes, high cholesterol, high blood pressure, they all thought that they were the picture of health up until the day they had their myocardial infarction. So based on that, decided to put together this registry in Boston of all individuals that have myocardial infarction who experience that under the age of 50, specifically to examine the risk factors and the outcomes of these young individuals. And in the article that we put together for this issue, which, by the way, fantastic issue. I've had a chance to really look at all the articles, and I'll show you one figure here. This is a figure from that article. But what we identify is risk factors that may be even more important in young individuals. So, for instance, and of course, a lot of these are known risk factors, but perhaps they have a greater weighing if we look at a younger population. And some of these we know, of course, like hyperlipidemia and diabetes and high blood pressure. But smoking, incredibly common in young individuals. In fact, we found that half of individuals who experienced a myocardial infarction at a young age were smokers. And in fact, if they quit smoking, they do so much better than those who continue to smoke. So a very important opportunity. And I always tell folks, it's never too late to quit smoking, even after your MI. Drug abuse, specifically marijuana and cocaine, certainly more prevalent in young individuals. Obesity, stress, that's a difficult one to study, but a lot of signals there. Family history, there's certainly a genetic component. We find that 10% of our patients met the clinical diagnosis of familial hypercholesterolemia. And then another condition, systemic inflammatory disorders. These are conditions like lupus or rheumatoid arthritis. And these are also conditions that once patients have them, they're more likely to experience events at a young age. Okay, so we recognize some risk factors and we keep on doing work on this. But the other concept is that even when we look at these risk factors, when we look at the traditional equations that we use to look at risk, so the pooled cohort equation, the ASCVD calculator, and we look at someone's risk of having an MI perhaps a month, 2 months, 3 months before their event, for the vast majority of individuals, if we looked at them right before the event, they would be classified as having low risk. And I think everybody in this group understands why that is. The reason for that is age is such a strong driver of risk that you can have a lot of risk factors, but if you're at a young age, the current calculators that we use will always say you're low risk, you're not a candidate for statins. So one of the things that we are hoping that some of our work will lead to more recognition that we can't just rely on the risk equations. We have to look at risk factors. And when we see young individuals who smoke or who have diabetes or who have high blood pressure, very important to treat those underlying risk factors and not say, well, you're at young or you're at a low risk, don't worry about it, which frankly is what's happening. And as a result, if you're a young person and you're admitted with a myocardial infarction today in the US, the likelihood that you are on statins is less than 5%. So, everyone who's coming in with MI at a young age, chances are they're tremendously undertreated. And of course, it's easy to look back in retrospect and identify that, but we now have to move to a prospective phase where we treat people prospectively. So certainly a lot of questions in this field. And I think one of the things that we hope for in the future is better risk equations specifically for young individuals, but also better approaches to identify risk in the young. Specifically, and I know the group at Methodist is really working on this, ways to screen for atherosclerosis, for example, on calcium score, and identify who are the patients who at a young age are going to benefit from further assessment, either by looking at risk factors, looking at genetics, looking at novel factors like lipoprotein A, or looking at calcium scoring as a way to identify risk earlier and start therapy earlier. So I'll pause there. It'll be more fun for us to have a discussion on this.
Dr. Blanson, for that intervention. Really very important points you brought up, and please stay with us because the question and answer session will be at the end. And now it's my pleasure to introduce our next speaker, Dr. Zul Javed. Dr. Zul Javed is an MD and PhD trained in Pakistan and in Texas, and currently is a postdoc research fellow here at Houston Methodist in the Houston Methodist Center for Outcome Research. His research interest has focused on health equity, social determinants of health, as well as financial hardship. And he has a very strong research method background. In the last year only, he has led or contributed to more than 10 peer-reviewed articles in this space. And he's here today with us, with Rahul Singh, because he contributed and was the lead author for the DEBAKEY Journal review titled Community and Social Context, an Important Social Determinant of Cardiovascular Disease. All yours.
Thank you so much for that introduction. It's such a great pleasure to share some of my work with this distinguished group of speakers. Let me start by sharing my screen. So, just like I said, it's such a pleasure to share this work. And before I get into our paper, I really want to thank Dr. Nasir and Dr. Cainzos for their leadership in really making this project happen and really giving someone like me an opportunity to contribute towards better understanding of such an outstanding public health issue. And just listening to the distinguished speakers before, I think this is a great segue into talking about social determinants of health, because a lot of the times in cardiovascular prevention, we tend to ignore some of these important risk factors or determinants of cardiovascular disease. So let me start by talking about some background of our paper. So as I alluded to before, traditional cardiovascular prevention frameworks have historically ignored the role of social determinants of health, or SDOH, which are now increasingly being recognized as primary drivers of disparities in cardiovascular disease, or CVD, which, of course, as we all know, is the leading cause of death in the US. Community social context, which for the purposes of this presentation, I've abbreviated as CSC, is a major Healthy People 2030 initiative, which I'm sure most of us know is the nation's premier program to improve population health. It is an integral part of the Healthy People SDOH framework, which serves as a blueprint for programs and interventions aimed at disparities and advancing the cause of health equity in the US. Now, current evidence suggests a positive influence of higher community and social support on psychological well-being and overall physical health. However, little is known about the association between key community social context factors and cardiovascular disease. In order to address this knowledge gap, the objectives of our review paper were to critically appraise current knowledge of the association between community social context and CVD, and really provide a framework to examine key community social context subdomains. At the same time, we also aimed to elucidate potential pathways and mechanisms via which community social context and its different constructs may predict adverse cardiovascular disease outcomes, and also identify opportunities for evidence-based interventions to improve CVD outcomes and reduce disparities. One of the three key takeaways from our paper is this framework, which I think I'm sure all of us have come across this in different forms and shapes and sizes, but I think one of the things that we set out to do was to give the readers an idea or a conceptual framework of how to examine community social contextual factors in the context of CVD. So really, this framework may be applied to study cardiovascular disease or other major clinical conditions. It can be used to look at community social context and its effects on CVD in general, overall, as well as look at the subdomain specific effects. Now, namely, we studied community social context under 4 subdomains, including social cohesion and networks, community engagement and civic participation, discrimination, and social support. Indeed, as depicted in the picture, these subdomains interact with each other as well as other social determinants of health to impact the risk of CVD. Based on our review of the literature, we found that poor social support, lack of social cohesion, and community engagement, as well as racial ethnic discrimination, are associated with increased risk of CVD. Conversely, positive social support, strong social networks, and regular community engagement were associated with favorable cardiovascular outcomes. We also found that the positive effects of community social context may manifest via several important pathways, including shaping health behaviors such as towards diet, smoking, alcohol intake, physical activity, as well as seeking routine healthcare, adherence to medication, and a variety of other resources, both monetary as well as psychosocial, to cope with things such as life stressors. In turn, these pathways play an important role in determining the risk of CVD. Finally, as depicted in this picture, these community social context subdomains may interact with other adverse social determinants of health, including socioeconomic instability, neighborhood disadvantage, food insecurity, and many others to impact the risk of CVD. As part of our literature review, we also developed a set of recommendations to improve current understanding of the community social context and CVD association, a few of which are shown here. In the interest of time, I would focus on 3 major gaps and recommendations. First, we found that there was substantial variation in terms of how individual community social context subdomains have been measured and reported in the literature. Hence, we recommended that future work should focus on developing standardized tools and measures to report different community social context constructs, in particular, social support, social cohesion, and discrimination. Second, potential variation in the social support and CVD relationship by race and ethnicity is mostly missing from the literature, which I personally believe is a huge gap. Finally, we recommend that community-level interventions to increase civic participation and social cohesion and address racism and discrimination should be informed by scientific evidence and engage relevant stakeholders for successful program design and implementation. In conclusion, poor social support and cohesion, lack of community engagement, discrimination, and negative or weak social networks are risk factors for cardiovascular disease. Community social context influences CVD via diverse pathways. And in that context, greater and stronger quantitative and qualitative evidence is needed to further understand these mechanisms. Future work should also include development of standardized measures and tools for each community social context subdomain, and really create opportunities for greater assessment of community social context burden for both primary as well as secondary CVD prevention. Thank you so much.
I truly think that this was probably one of the most important papers in the issue, in part because this is an area that has been so much disregarded by all of us, and is such an important part of prevention. Also, a tough one to deal with and to do some research. So I hope that you will continue to pursue, because I think we do need clinical trials and whole new innovative ways of thinking through. As you know, Valentin Fuster a few years ago was proposing maybe a poly pill, one pill to fix. That would be very inexpensive because of the nature of the beast. how difficult it is to handle this particular problem. So thank you for being a co-author with in an excellent article and putting this up in the upfront, because it's a very important topic. So it's my pleasure now to introduce one of our guest editors who have been sitting in his office. It's time to get him out here, Miguel Cainzos. And thank you, Miguel, again for being a guest editor for the issue. And it's your job now to tell us a little bit about should we still be giving aspirin to everybody? Should we put aspirin in the water or not?
Thank you so much, Dr. Quiñones. Thank you, everybody. Thank you to our speakers today and to the authors of the DEBAKEY Prevention Journal issue. It's been a wonderful experience to work with all of you. And today I'm going to be presenting or summarizing this wonderful article by Murphy, Corneen, and McEvoy, in which they talk about the role of aspirin in primary and secondary prevention in the modern era. I don't have any relationship with industry to disclose. And again, I want to thank Dr. Quiñones, Dr. Nasir, and my friend Dr. Patel for the opportunity to work with all of them in this issue. It's been a wonderful experience. I'm looking forward to future collaborations, and it was also very, very nice to write the editorial for this issue. And as I mentioned, I'm going to be summarizing this article by Corneen, Murphy, and McEvoy on the role of aspirin in primary and secondary prevention. They were not able to join us today, but they did an absolutely terrific job with this paper. Particularly Dr. McEvoy, I'm sure you know about him. He has been a leader in this space since 2018. He's a full professor of preventive cardiology in the National University of Ireland in Galway. And he has been a leader in this space, including participation as co-author in the 2019 ACC/AHA primary prevention guidelines, of which he was one of the key authors, and particularly he had important contributions in terms of the role of aspirin in primary prevention. He is also an adjunct faculty in the Johns Hopkins University School of Medicine, and he has multiple appointments in Europe as well. He actually has been leading key papers in this space in 2018, including this landmark review in The Lancet in 2019, the famous Rise and Fall of Aspirin Primary Prevention paper, which I strongly recommend you to read if you're interested in this space. And also in secondary prevention, he recently led a senior author of this paper in Circulation, in which they discuss whether aspirin might have a maybe not so relevant role in secondary prevention in the near future. I think this figure on the right is very, very illustrative of the challenges that aspirin is facing right now as a therapy in secondary prevention as well. Based on this background work, we thought that definitely the Galway team would be the perfect leaders for this update on the role of aspirin in primary and secondary prevention. We were very lucky to have them accept this invitation, and I honestly think they did a fantastic job with this update. The authors discussed the mechanisms of aspirin, the antiplatelet mechanism that we all know about, but they also focus on the risks of aspirin therapy, including a bleeding risk and particularly gastrointestinal bleeding risk, which we always need to think about when we think about using these kind of medications, and particularly aspirin in our patients. They also discuss the context, and it's very important to keep in mind that the usefulness of aspirin nowadays might not be as much as 30 years ago when the initial trials were conducted. This is a consequence of the fact that our populations nowadays, they have lower rates of first and recurrent ASCVD events, particularly in countries like the US and the European countries. This is a consequence of secular trends, anti-tobacco laws in many countries, a better management of multiple risk factors, better alternative therapies like clopidogrel, ticagrelor, and others, and also the fact that we are currently able to manage better acute MIs, which means that we are going to have fewer subsequent events, and therefore the role of aspirin might not be so relevant in those patients. And in parallel, during these 30 years, the risk of bleeding with aspirin has remained stable, has not changed. And actually, it might have increased because now our patients are older, they are taking multiple medications, and they are more frail, and they have more comorbidities. So the balance of risk and benefit with aspirin has changed quite a bit over time. The authors also discuss the guidelines, the role of aspirin in primary and secondary prevention. I'm not going to go through these tables, but I definitely encourage you to review the paper because I think it's very rich and a landmark contribution to this field. And they also discuss ongoing trials in secondary prevention, both in individuals without an indication for oral anticoagulation and also among individuals with an indication for oral anticoagulation. I think these figures speak to the level of detail and the high amount of work that the authors put in this review. And I think you're going to find these figures very informative about ongoing trials and the expected, well, at least the strategies that are being tested in each of them. in terms of the key messages that the authors presented in this review, I think in terms of primary prevention, we would all agree that after the 2018 trials, the Aspirin, Ascend, and Arrive trials, we could safely conclude that in the majority of patients in primary prevention, we are not going to need aspirin, or aspirin is not going to be a good option for most of our patients in primary prevention. However, there's a minority of patients in whom this therapy might make sense. And both the ACC/AHA guidelines in 2019 on the left, and also the most recent ESC guidelines in 2021 on the right, both of them are actually recommending consideration of aspirin with a 2B8 recommendation in those individuals in primary prevention, meaning individuals who are asymptomatic or clinical ASCVD, but who have a very high risk of having an event. Those individuals, they might have event rates as high as individuals from secondary prevention populations. And if we're able to identify those who are at low bleeding risk, aspirin might be a good option for those individuals. These are going to be a minority, but in terms of absolute number of patients, this could actually be a large number of individuals. The expected benefit with aspirin, the authors described this as a modest benefit, even though we need more trials to understand what would be the relative risk reduction, specifically individuals with very high burden of plaque in primary prevention. And obviously, they stress the need for the patients to be informed about the benefits and risks of this intervention, of this therapy. And they mentioned the CAC score, which obviously is a topic that is very close to our research here in UC Methodist. They mentioned the CAC score as a potentially relevant tool to identify individuals among those who are at low bleeding risk, identify those who are at highest risk of ASCVD events. That's definitely consistent with our research. This is a paper that we published in Circulation last year with the Ciccaroni team, Dr. Nasir, Dr. McKeown was also an important co-author in this paper. And also recent studies in other populations, like the Dallas study, where they also identified that among individuals at low bleeding risk, CAC it's actually not a very good tool to identify bleeding risk, as you can see on the left, but actually it's a fantastic tool to identify individuals at high risk of ASCVD events. So CAC might be the way of implementing those recommendations from current guidelines in terms of aspirin in primary prevention. So if you're interested in this topic, let me just mention this briefly. We are going to have this dedicated event December 1st. We're going to be talking about aspirin in primary prevention. We're going to be talking about the potential role of CAC in the allocation of this intervention, specifically in individuals who are asymptomatic but at very high risk. So I think we're going to have a fantastic panel of US and European speakers, and I invite you, all of you, to join us online for this event. And to conclude, in terms of key messages in secondary prevention, I think the authors clearly made a point for aspirin being having a stronger evidence for its use in secondary prevention patients. It has been traditionally considered a core therapy in these individuals, but they also discuss whether with recent trends, there might be an opportunity to change this paradigm, and maybe aspirin might not be so relevant in the near future also in patients with secondary prevention settings. There are multiple trials going on that are evaluating strategies that would include only other antiplatelet therapies and without using aspirin after the 12-month follow-up period. Trials that are evaluating exclusively aspirin without any other antiplatelet therapy. And there are even trials that are interested in evaluating whether in patients at high bleeding risk, there might be a possibility to actually avoid any antiplatelet therapy and focus on other medications that are not associated with bleeding, like statins, improved blood pressure management, and a more aggressive management of the other risk factors. These are strategies that are right now being tested in ongoing trials, and we look forward to those results. And the figures that I just showed you describe the design and the strategies evaluated in each of those studies. And finally, they stress the fact that among individuals who have an indication for anticoagulant therapy, current guidelines would recommend to discontinue aspirin after 12 months of follow-up. So that is all. This was a brief talk. We could spend the full hour talking about aspirin as well. Again, I invite you to join us on December 1st. And again, I would like to congratulate the authors for the terrific work that they did. I also thank Dr. Quiñones for his leadership and Dr. Nasir for the opportunity to be part of this team. Thank you so much. I'm looking forward to the Q&A session. Thank you.
Well, great. Thank you so much, Miguel, for summarizing such an important article for this issue. We're going to transition a little bit to another key aspect of prevention when we talk about cholesterol, specifically very high levels of cholesterol or severe hypercholesterolemia. And so I have the honor to get to talk about this next article titled "The Past, Present, and Future of Familial Hypercholesterolemia." Our authors of this paper, unfortunately, were unable to join us, but we are very thankful to Dr. Rocha and Dr. Santos. Our authors are affiliated with the University of Sao Paulo Medical School Hospital. Dr. Rocha has published extensively on the role of risk stratification and inflammation, as well as familial hypercholesterolemia. And Dr. Santos is a preventive cardiologist at the same institution, whose clinical and research interests have focused on reducing the burden of atherosclerotic cardiovascular disease associated with familial hypercholesterolemia. And he's the president of the International Atherosclerosis Society. And as a co-editor, we would like to congratulate the authors on this excellent article that they have shared with us. So I'll summarize briefly some of the major points from this article. And, for this audience, and others, briefly, familial hypercholesterolemia is one form of severe hypercholesterolemia. And this leads to premature coronary heart disease related to those elevated levels of LDL cholesterol. And essentially in familial hypercholesterolemia, we think that there is a inefficiency of the liver to clear LDL cholesterol from the bloodstream, likely related to abnormalities in the LDL receptor. And subsequently, those high levels of circulating LDL cholesterol can then deposit into the arterial wall that can subsequently lead to inflammation and plaque formation, which in certain states, like inflamed states, can rupture and lead to acute myocardial infarctions. And so we know that the familial hypercholesterolemia is inherited in an autosomal dominant pattern with 3 separate genes that we know about. The most common being an autosomal dominant variation in the LDLR gene that encodes for that low density lipoprotein receptor. And the prevalence of FH, or familial hypercholesterolemia, is much more common than we thought. About 1 in 300 individuals have FH. And when we look at patients who we may be seeing in the hospital who have had a myocardial infarction or premature coronary heart disease, the prevalence of FH is even higher. And so it's important that we recognize the clinical diagnosis, which is based off of LDL cholesterol levels, family history of premature coronary heart disease, or family history of elevated levels of cholesterol, as well as physical exam findings. And so with familial hypercholesterolemia, it's important to not ignore the genetics. There are pathogenic variants of these genes that are associated with worse outcomes compared with those with high levels of cholesterol in the severe hypercholesterolemia ranges that do not have specific genes identified. And it's also important that as the authors highlight that this genetic aspect is important for family cascade screening, and it's in part because of this autosomal dominant pattern of inheritance. And another reason why this was an important contribution to this issue of the journal is because there has been an immense evolution of the therapies that we have for familial hypercholesterolemia, and the authors do an excellent job highlighting these. Statins have been the mainstay of therapy that lead to reductions in LDL cholesterol, but now we have newer therapies, and those therapies can be guided based off of risk stratification tools. And the authors highlight that in this table, looking at the actual biomarkers of the LDL cholesterol level, as well as other markers such as lipoprotein A that Dr. Blankstein mentioned, as well as other factors like other lipoproteins like HDL cholesterol, as well as risk factors such as smoking, high blood pressure, and diabetes. There are various definitions for the familial hypercholesterolemia severity. And then, as has been touched upon earlier in this forum, the role of atherosclerotic imaging, like coronary artery calcium. And the idea here that the authors suggest is that patients at higher risk who need more aggressive LDL cholesterol lowering, identified based off of some of these different biomarkers, may warrant more aggressive therapy. And the armamentarium we have now to lower cholesterol has increased rapidly, with therapies such as inclisiran that can reduce the amount of LDL cholesterol circulating with less frequent injections as compared with the relatively new PCSK9 inhibitors. And then there are some newer therapies that are even in the pipeline, such as monoclonal antibodies like evinacumab that are targeted against ANGPTL3. And someday in the future, we may even have some tools to edit genetically to reduce LDL cholesterol with CRISPR-Cas9 type therapies. So again, I want to congratulate the authors for an excellent contribution to this issue, talking about familial hypercholesterolemia from multiple different angles, and we are grateful that they were able to contribute. We wish we could have them for the question and answer, but we will try to address any of those questions, so please feel free to continue to text, and we will attempt to answer some of those questions later on. So next, I would like to introduce Dr. Avenatti for the next part of our presentation.
Thank you, Dr. Patel. And I do have the honor to present another one of the articles present in this wonderful issues, a work that was submitted by Dr. Sharma and colleagues regarding prevention starts in the womb. Opportunities for addressing cardiovascular risk factors during pregnancy and beyond. Traditional cardiovascular risk factors such as hypertension, smoking, dyslipidemia, and obesity have been associated with adverse pregnancy outcomes, or APOS. On the other hand, APOS and another group of sex-specific disease like PCOS and premature menopause have been associated with an increased risk of cardiovascular disease and mortality. The authors so make the point that pregnancy is an actual perfect window of opportunity to try and address both traditional and sex-specific risk factors and cardiovascular disease. The importance of such a window of opportunity becomes clear when we stop and think that, as mentioned before, cardiovascular disease and cardiovascular mortality has actually increased over the last decade. Specifically, pregnancy-related deaths in the United States have gone up over the last 25 years, and most of those deaths are actually related and due to cardiovascular diseases. Part of this is due to the rising prevalence in women of childbearing age of traditional cardiovascular risk factors such as hypertension, obesity, and dyslipidemias. Now, major scientific societies have focused on addressing traditional risk factors, and those have brought us some important, significant tools to address those risk factors and start conversation with our patients, such as the Life Simple 7 from the AHA or the ABCD approach from the ACC-AHA guidelines in 2019. Along the same lines, authors in this wonderful review provide us with a toolkit in 7 clear steps to address traditional risk factors in pregnant women. So going through the toolkit, basically, they do address chronic hypertension, reminding us of the fact that clear cutoffs for treatment are unfortunately not available because of the lack of clear EBM data. But they do remind us that we should start treating hypertension for blood pressure above 160/105 in the absence of organ damage. And they do remind us that unfortunately our drug choices are very limited in this specific setting. So we have a green light with beta blockers, calcium channel blocker, and alpha-methyl-dopa, but of course absolute contraindication for the use of ACE inhibitor ARBs or MRAs. As far as dyslipidemia management, again, this cornerstone will be diet and lifestyle changes. Unfortunately, statins are category X in pregnancy, so we have to be aware of this and we have to avoid those medications. Those should actually be discontinued 1 to 2 months before pregnancy is considered and not restarted until 2 months after, or at least until breastfeeding is completed. Recommendation regarding obesity, smoking, and physical activity are actually the same as for the general population. So encourage pre-pregnancy weight loss, smoking, and actually cessation of every type of tobacco products. And in that case, better outcome have been demonstrated if that is achieved before the 15th week of pregnancy. And physical activity, the actual recommendation is the same as for the general population, 150 minutes of moderate intensity activity every week. For diabetes, once again, limited option as far as therapy go. Insulin will be the cornerstone of the therapy, encouraging lifestyle and good diet choices. Important to remind, possible need for more frequent checks for A1C due to a higher turnout of the white blood cell. and specific attention for patient at risk for preeclampsia. In this patient, we might need to consider the addition of aspirin, low-dose aspirin daily for prevention in those specific high-risk populations, so preeclampsia, diabetes, both type 1, type 2, CKD, any autoimmune disease. In the second part of their review, the authors focus on the negative effects of sex-specific risk factors on cardiovascular health in general. And they do focus on the adverse pregnancy outcomes, as we mentioned before, PCOS, as well as premature menopause. Now, this specifically are now considered risk-enhancing factors in the assessment of atherosclerotic guide at risk to guide statin therapy for women at otherwise intermediate risk for atherosclerotic cardiovascular disease. And this is a table from the 2019 ACC/AHA guidelines. Specifically for preeclampsia, it has been associated with a 4-fold increase in risk of heart failure and a 2-fold risk increase for cardiovascular disease mortality, CAD, and stroke. For premature menopause, the author do underline how it is related to an increased risk of cardiovascular disease and mortality, such as unless there is an absolute contraindication, the ACOG recommend hormone therapy in women with premature ovarian insufficiency until the average age of natural menopause, so age 50 to 51. And finally, for PCOS, the data here is less clear. It has been associated with subclinical cardiovascular disease, insulin-resistant hypertension, but there is an unclear association with overt CVD. Despite this, the author do recommend that until definite data is available, PCOS should be treated as a significant risk factor for CVD, regardless of patient's BMI. So in summary, the key points that the author really do drive home is that in addition to screening for traditional cardiovascular risk factors, providers should screen for sex-specific risk factors because the interaction between those two is extremely important. And pregnancy becomes an opportune time to identify women who are at risk for future cardiovascular disease and intervene early, so just that we could not only improve pregnancy outcome, but long-term cardiovascular health. So that was my quick review. I know we're late, so we're trying to speed up. And it will be my honor to introduce our next speaker, Dr. Eamon Duffy. Dr. Eamon Duffy is an MD trained at Johns Hopkins at the prestigious Osler residency, and currently is a cardiology fellow at Columbia University in New York. Dr. Duffy is a talented clinician and a writer, and has research interest in cardiovascular prevention, wearable technologies, and healthcare system enhancements. During the COVID-19 pandemic, his work identifying opportunity to enhance the prevention of cardiovascular disease has been published in major journals, including Circulation. In this most updated review in the DEBAKEY journal, he discussed important lessons learned from the pandemic in terms of novel approaches in cardiovascular prevention and risk management moving forward. Dr. Duffy.
Great, thank you so much for having me. It's an honor to be on this panel. I will be sharing my screen. So I'm going to talk about cardiovascular disease prevention during the COVID-19 pandemic, and my subtitle, Great Disruption Brings Great Opportunity. Hopefully we'll leave this brief talk knowing some of the lessons from the pandemic that has so defined the last few years throughout this country. No disclosures. No need for this slide with this audience, but what I like so much about cardiovascular disease prevention is that it's really about aligning a patient's life with their cardiovascular health. And with the COVID-19 pandemic, that entire life was turned upside down. And with that topsy-turvy life, our CVD prevention efforts were also turned upside down. I don't think that the last few years have been 2 steps back. I think that there were many steps forward, and it's important that we leverage many of these lessons from the pandemic as we move forward. I'll start with some brief discussion of disruption for providers. In-person cardiology office visits dropped over 60% in some areas of the country. Many of you experienced this. I'm a cardiology fellow and have now moving up to New York, where I'm working currently. Not a day goes by where I don't see the impact of the pandemic on the care that we provide. Primary care visits, during which so much CVD prevention takes place, dropped over 20%. That's both tele and in-person visits throughout the early periods of the pandemic. 50% reduction in blood pressure evaluations, 38% reduction in cholesterol level evaluations. These are really the bread and butter of so much of preventive cardiology. And due to the pandemic, we really weren't able to pursue it. Cardiac rehab programs were halted overnight, canceling millions of sessions for this really important resource. Disruption for patients, huge decline in physical activity, not just across the country, but around the world. Fitbit has been publishing their data regularly. And, the first few months of the pandemic, you saw a massive decline in the parts of the country and the world where the pandemic was most severe. Diets have changed even more dramatically. 85% of people reporting changes to their eating habits. A study found 27% of participants reported weight gain. With all of this, screen time has skyrocketed. So many of these streaming companies are doing better than ever, Zoom in particular, because we're all at home, we're all on a screen, but that leads to sedentary behavior, which is a CVD risk factor. With all of this, increasing rates of stress, anxiety, depression, loneliness, social isolation, all known risk factors for CVD. And this really defined the pandemic for so many of our patients and made it so challenging to meet their healthcare goals, to meet their CVD goals, and to move their health in the right direction. Opportunities for providers. I think cardiology is in an amazing position to leverage the lessons learned from the COVID pandemic, particularly in the telemedicine space. After primary care, the field of cardiology experienced the greatest relative migration to telehealth platforms by volume. In the early months of the pandemic, hypertension, hyperlipidemia, and diabetes ranked 1, 2, and 4 for the top indications for telehealth appointments. Those are, some of the most important issues for our patients, but it shows that these topics can be covered in telemedicine visits. Preventive cardiology visits really lend themselves uniquely well to a virtual visit. The physical exam, hugely important, at the first visit, but at subsequent visits, so much of it is about discussion with the patient, talking about motivations, talking about lifestyle, diet, exercise, medication adherence. Also, pharmacy delivery services significantly expanded during the pandemic, an area I'm interested in. There have been some small studies that have shown that if the med is delivered to your door, you're more likely to be adherent. That makes sense. And as people couldn't leave home, these services became more popular. Opportunities for patients, exercise, diet, smoking cessation. There were really some sort of silver linings to the pandemic. Large increases in high intensity training. Home exercise has really taken off. We've seen the success of Peloton and many similar companies. People were figuring out ways to be healthy at home. And I think that's really exciting. Diet-wise, increased rates of cooking at home for obvious reasons, but those are good lessons to learn. Many studies focused on more snacks, but hidden in a lot of that data, people are eating more vegetables, also a great sign. Smoking cessation, 20% of smokers report cutting back. A third of smokers were more motivated to quit due to the pandemic. It's a respiratory virus. People are more sort of cognizant of having healthy lungs and healthy hearts. The right side of the slide, I think, is most important. And that is really, for the first time, at least in my life, health has been the most important thing in this country in many ways, as there's a virus that's being transmitted. People are much more cognizant of their health. How healthy are they? How healthy are their family members? And I think we need to leverage that focus on health as we move forward, hopefully out of the pandemic, keeping health at center stage, keeping cardiovascular disease health at center stage. It's very important to pause and discuss how disruptive this pandemic was for our most vulnerable patients. This is a great quote that sums it up from Vivek Murthy, but there's no doubt that the pandemic affected the lower socioeconomic status, some minorities and the elderly to a much greater degree than people who don't fall into those categories. And so we need to really focus on those groups as we move forward. This was an interesting study published recently in JAMA that looked at patient use and clinical practice patterns of remote cardiology visits during the COVID era, looked at almost 200,000 visits and compared pre-COVID in-person, pre-COVID tele to COVID tele and COVID video, and found that during the COVID era, video and telephone visits, were successful in reaching some of these minority groups. Key to note that more popular or more used in patients who have private insurance. That's a major issue and a major barrier. But the way that we practice medicine via telemedicine is different than how we practice it in person. And that's an important lesson. Video and telephone visits were significantly lower odds of ordering any medication as well as most tests. Now, in many cases, that's a good thing. Maybe we're bringing down some of our heavy ordering practices, but too often I think that these televisits are more check-ins and less practicing true medicine. And so that's a lesson that we can take as we move forward. Final slide here, what are the major lessons from my perspective? And I really look forward to hearing from you all about your experience through all of this. We have to capitalize on the good habits that developed throughout the pandemic, healthy eating, a new focus on exercise, but so many of our patients have been inactive for the last few years, and we really need to put extra focus on getting them active again, getting them out of the house. Preventive cardiology visits can easily be adapted to telemedicine. I think that's been shown, but we have to make sure that we're practicing medicine and that we're not just checking in. We're willing to order those labs. We're willing to up-titrate medications. It proved that telehealth can be a viable strategy to improve access for seniors. They've done well through the pandemic and really shown themselves to be a group that can access telemedicine, is very facile with Zoom and many of these new technologies. And lastly, health is at center stage. Let's all try to keep it there. So thank you all so much for having me. It's an honor to be here, and I look forward to the discussion. A brief thank you to three of my favorite people in the world.
Excellent. Thank you, Dr. Duffy, for that excellent summary of an important contribution to this issue of the journal. For our next talk, we have Dr. Mohammed Taha. He was the lead author of our next paper to be discussed, a checklist approach for enhanced outpatient guideline-directed management and the secondary prevention of atherosclerotic cardiovascular disease. Dr. Taha is our inaugural cardiovascular disease prevention fellow here at Houston Methodist. He has a research interest in obesity and cardiometabolic disease and its cardiovascular disease manifestations and how we can prevent those, as well as innovative models for how we can prevent cardiovascular disease. And so, Dr. Taha, we are glad to have you here to highlight some of the major points of this innovative model, this checklist approach. We look forward to your thoughts.
Thank you so much, Dr. Patel. It's such a great honor and pleasure to be here to talk about my recent work. Let me share my screen. First, I want to thank Dr. Cainzos and Patel and Dr. Nasir for their mentorship on this project. In this review and proposal, basically, we are proposing a checklist-based approach to improve the management of patients who have established ASCVD. So I'm going to start by saying, why are we choosing the checklist-based approach? And there are multiple valid and really important reasons to go with the checklist approach. We know that the ASCVD is the leading cause of morbidity and mortality in the country and globally. And we know that if a patient has an established one ASCVD event, there are more risk of having a future event as well. We know that there is an abundance of availability of high quality evidence and clinical practice guidelines with the proven benefits in patients with established ASCVD. And number three, despite these high quality evidence and guidelines, there are still significant gaps in the management of patients with established atherosclerotic cardiovascular disease. And unfortunately, many of these reasons are related to provider unable to initiate or intensify medical management. And number four, we know from within the medical field or outside the medical field that checklist approach work. They are organized tool. They guide users to ensure that similar standards are applied all the time. These figures highlight some of the gaps in managing patients with established ASCVD. To the right, we see that it shows that the rate of lipid intensification therapy in patients who have LDL more than 100 is only 22%. And to the left, we see that the rate of adherence to cholesterol treatment guidelines in ASCVD is actually less than 50%. So how did we develop this checklist? We had certain principles to build up this checklist. Number one, we wanted to include core health components and major risk factor management. And number two, we wanted all components of the checklist to be based on high quality evidence and recommendation from major societies like AHA and ACC. And number three, we wanted the checklist to be not to be exhaustive, but rather concise and serve as an overall reminder for the providers. At the end, we managed to come up with a 13-point checklist that focused on the treatment of ASCVD. This is the final checklist after multiple revisions and improvement. It includes guidance to ASCVD diagnosis, and then quick point on lifestyle intervention and management of antiplatelets, dyslipidemias, blood pressure, diabetes, overweight and obesity, as well as smoking. The checklist is only one component of a more comprehensive tool for enhanced guideline-directed management in patients with ASCVD. The other components can include educational material, such as in-person and online lectures, practical handbooks, and pocket cards. We also propose to utilize electronic medical records in multiple ways. For example, integrating the checklist with EMR, creating dashboards to remind providers and highlight the gaps in medical care. In addition, using EMR to assess the quality of medical care provided before and after we implement our project to further guide the quality of our project. This is basically my proposal and review, and thank you again for having me on this live hour.
Dr. Taha, for summarizing this very important topic in a brief way. As those of you who are still watching us, we've gone a little bit over time. I hope that you have really gotten the message that there's a lot more to cardiovascular prevention than just giving a statin and aspirin. And this is really an area where it's progressing very rapidly. We can take a few minutes for questions. Do we have any questions in the screen? If not, I do have one. Okay. I wanted to ask Dr. Blackstein, is he still with us?
Not sure.
Not?
No,
Yes?
Dr. Blackstein had to leave.
Okay. Well, any one of you can answer this because, he was talking about the challenges of identifying risk in the young people. And one of the questions I had is, because so many of these young people have a soft plaque, more soft plaque than calcium, the calcium score may not always be positive in them. Have there been any work with the IMT, the carotid IMT, as a way in a 25-year-old who has a fair amount of risk factors to possibly pinpoint that patient is at higher risk and may need more aggressive treatment? Who wants to take that? Miguel? Okay.
Yeah, I'm happy to take this one. Actually, we have a paper in press right now in the American Journal of Cardiology where we evaluated MESA participants with a CAC score of 0 who were younger than 55 years of age. And we evaluated specifically this question. First of all, we wanted to see whether having a CAC score of 0 in young individuals is sufficiently reassuring. We know that this had been challenged recently in Circulation and other journals. And what we observed after 17 years of follow-up is that the event rates were very low. This is a paper that is in press, still not published, so I cannot provide much more detail, but I think the results are going to be very reassuring. I think also you're going to find very interesting the results for carotid IMT, which I think is, in case of needing additional information, in case of uncertain treatment with a CAC score of 0, seems like a very interesting test that can provide additional information.
So without giving too much data out, you would support the idea of using an IMT in a 30-year-old who, let's say, has several of the risk factors to further define whether they are at a very high risk?
I think in most patients, in most young patients with risk factors, we would all agree that aggressive lifestyle intervention is definitely needed regardless of presence or absence of plaque, because if they don't have plaque, they're going to develop it if they continue to smoke, if they are physically inactive. So definitely the focus of the intervention, in my opinion, would be, and I think this is very consistent also with the paper by Dr. Blankstein and colleagues, a focus on aggressive lifestyle intervention. We also need to think about primordial interventions, primordial prevention, trying to reduce the burden in the full population, right? Exposure to tobacco products, exposure to fatty trans fats and so on, and sugar, added sugar in foods. But in that patient who is young, has a CAC score of 0, but for some reason maybe they have a strong family history, they want to be further reassured. Yes, I would say that would be an interesting option to evaluate the carotid arteries with the latest technology. But let me be cautious and invite you maybe next week to check the paper in the American Journal of Cardiology.
Excellent. All right. Okay, we have 1 minute for final comments from Dr. Patel.
Yes, I want to, on behalf of my co-editors, want to thank all of the authors who have contributed to such a nice finished product that has been many months in the making. And again, thank Dr. Quiñones' leadership as the editor for this journal for inviting us to help in terms of putting together a prevention issue. As we've all seen, as Dr. Duffy has highlighted, even in such trying times such as this COVID-19 pandemic, the importance of cardiovascular disease prevention hopefully will have a bright light on it in the future, because as we've seen, there's many aspects to this highlighted by several of these author groups, all the way from primary prevention in young individuals who may be suffering from acute myocardial infarctions at an early age, to looking at things like social determinants of health, innovative models as using checklists as to how we could potentially mitigate some of those risks in the future, thinking about risk factors as early as before pregnancy or during pregnancy or shortly thereafter. There are many ways in which preventive cardiology can emerge in terms of cardiovascular disease programs, and we're hoping that our issue in this Methodist DEBAKEY journal will help highlight that. Again, I want to thank everyone for tuning in and being a part of this and listening and learning, hopefully. And all of these journal articles have individuals who are willing to be contacted as part of their issues, and so please feel free to reach out to them as well as the co-editors for further questions. And we hope to continue to spread the word about cardiovascular disease prevention and continue to learn as we do from all of us here in cardiovascular disease.
Thank you very much for attending this, and have a great day.